Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. I am so glad you guys are tuning in today. We have such an awesome topic. I can't wait to get this out and have it drop and have you guys listen and then learn. Oh my gosh, so much good stuff. However, before we get started, I wanted to just make sure you are aware of all of the amazing 100% free virtual programs we offer at survivingbreastcancer.org. Sometimes these are programs you didn't even know you needed until you actually experience them. For example, the incredible expressive writing classes that we host for all stages of breast cancer, early stage, as well as those living with metastatic disease. We have expressive art therapy classes. We are doing weekly meditations. We have support groups for metastatic early stage inflammatory breast cancer. We are doing like hypnosis these days, like all sorts of integrative oncology inspired programming, 100% free to you. So check it out, survivingbreastcancer.org/events. All right, so what's going on in the podcast today? Today, I am so thrilled to be talking to Dr. Rachel Layman, who is a professor at the University of Texas MD Anderson Cancer Center, and she works in the Department of Breast Medical Oncology. At MD Anderson, she co-chairs the Hormone Receptor Positive Breast Cancer Clinical Trials Working Group and is the director of clinical research for the Morgan Welch Inflammatory Breast Cancer Clinic and Research Program. She is actively engaged in breast cancer clinical trials and translational research and has led numerous clinical trials, which is why we're talking to her today, specifically about the top-line data from the PIK3CA wild-type cohort, Study 1, of the Phase 3 Victoria 1 clinical trial. Welcome to the conversation.
My name is Rachel Layman. I am a professor in breast medical oncology at MD Anderson Cancer Center in Houston, Texas. I am a native Ohioan. I grew up in Ohio. I did my med school and undergrad at Case Western in Cleveland, Ohio, and my residency as well. And then I went to University of Michigan for my fellowship training to specialize in hematology oncology. And then I worked at Ohio State for about 8 years prior to coming to MD Anderson, where I've been for about 9 years. My major research interest is in ER positive breast cancer, which is the topic of discussion today. I've been very interested in finding new treatments for this type of breast cancer. And I have some additional interests as well, such as inflammatory breast cancer. But I know we're going to be mostly talking about ER-positive breast cancer today.
Yeah, and ER-positive breast cancer is one of the more prominent breast cancers when people are diagnosed, correct?
Correct. And so that's why it's so important. If you look at the vast numbers of breast cancer diagnoses, the vast majority are going to be ER positive. And I know that sometimes triple negative breast cancer gets a lot of press because it tends to occur aggressively, but there's fewer of those, fortunately. So even though ER positive breast cancer is less likely to metastasize or recur, still most patients, even with metastatic breast cancer, are going to have ER positive breast cancer. So it's a very important area to improve the lives of these women.
Absolutely. And so I personally, I'm also ER positive, hormonal positive receptor when I was diagnosed about 8 years ago. And, I think when we talk about clinical trials and trying to support those with advanced breast cancer, whether you're, late stage metastatic or, sometimes stage 3 get included in these clinical trials as well. It's really important for people to know that when you're getting research done, it really kind of trickles down and helps everybody. And how do you recruit people for clinical trials? I know we try and do a lot of work at survivingbreastcancer.org to kind of demystify some of the scary things of like clinical trials, letting people know that they're getting not just the standard of care, but perhaps better than the standard of care. And I think there could be some fear around, what type of side effects are we going to be experiencing? And, what's the requirement for coming in for treatments, different things like that. But how has your experience been recruiting for clinical trials?
Yeah, there's a lot of facets to consider there, and some patients come in really wanting to do a clinical trial, wanting to do something new, and other patients really have never really um, had experience with it. They may have heard that there's clinical trials, but don't know much about it. So I think that it's always important to present what the current standard is. So if you weren't going to do a clinical trial, what would we do or what are our options? And then that helps to compare what the differences would be when you're on a clinical trial. And so it depends on the clinical trial. Like some clinical trials are using the standard of care and adding onto it. Some clinical trials are trying a completely different regimen. So I think that taking the time to explain the current standard and what would be different about the clinical trial therapy is important. Also, the type of clinical trial it is, some clinical trials, you know exactly what you'll be getting. Other clinical trials, there's a randomization where some patients might get the standard and some patients might get the clinical trial treatment. So explaining that. And I also think I have probably the most success in recruiting patients that I know that I have a rapport with. I think that trust is very important with your oncologist in general, but especially when discussing a clinical trial. And so, someone that's never met me before may not have that trust and rapport in having the courage to enroll on a clinical trial because I do think it take everything about a clinical trial and breast cancer treatment takes a lot of courage. Um, but my patients who know that I truly have their best interest at heart, um, and they can trust me when I say that this is a good option. I have a lot of optimism about this clinical trial. I think that always helps as well.
Absolutely. And the timing of the clinical trial, it doesn't have to be when a patient has run out of other lines of treatment or other options, correct? You can kind of present this as, you know, you have these options, or is it really coming in at, okay, there are no more options, let's explore clinical trials? When should the patient start inquiring about this?
Yeah, I mean, there is this misconception that it's a just a last ditch hope. Like there's no other options. Let's try this clinical trial. I think that those are important. So, doing considering a clinical trial when there are no other treatment options, um, these are important trials to do. Um, but honestly, like when a clinical trial is most likely to make the most impact is earlier in treatment. Um, the um, the last treatment that a cancer has seen, um, the more likely it's going to respond to anything, whether it's a standard treatment or a clinical trial. And it's if we give a better treatment or a potentially better treatment earlier in the course, then it may make a larger impact in the long term over the total course of the disease. And so every type of clinical trial is important, even in patients that are getting curative treatment, because we know that we can't cure all patients. And so, if we give you a new treatment that results in a better chance of cure, and you never recur, then that's going to have a much higher impact than than a drug or a treatment that is given after you've already recurred.
Absolutely. It's so interesting because I was diagnosed about 8 years ago, and even the treatment regimen that I was on has evolved. And so talking to those who are newly diagnosed, it's fascinating to hear. Like, I feel so old. I'm like, in my head, this happened like yesterday, right? However, when talking to other people, they're like, "Oh, we don't do that anymore." So it's wonderful to hear that are happening.
Yes, and we're in such an exciting era right now because the pace of new treatments is happening so fast that it's even becoming challenging on how to design clinical trials because the standard of care at the beginning of the trial may be different than at the end, which is honestly a great problem to have because that means that we are improving treatments much more quickly than we were a decade ago. And so it's this is true that we are treating cancers different than even a short time ago. But it's just such an exciting time. I think what we have been able to learn about what makes a cancer work, what kind of changes we see in a cancer, and how we can attack that cancer, it is finally starting to translate into actual treatments and improved outcomes.
Very exciting. So let's dive a little bit deeper into like a specific example. I know you have been working on the Victoria trial. Can you give us a little bit of that background from its like incubation phase all the way up to where we are today? And then I know we want to dive into some of the results that just got announced not too long ago. So, but first, what is the Victoria trial? What were you trying to ascertain?
Yes. So I am so thrilled about this trial. So I have been involved with this new drug, Genitolasib, since it was a phase 1B, which is the very earliest evaluation of a drug, um, and for years and years. So what I remember when we were treating patients with this drug, we were very, we had a good feeling about it. So whenever you're using a new treatment, you just never know what's going to happen. And there's some drugs that you're like, oh, this is not living up to my expectations, but let's see. And there's others that like, wow, this looks promising. And not just me, but other of my colleagues and the research staff also because they were like, "Oh, I like this drug." Um, so um, so it was really exciting, and so many drugs don't make it to phase 3 because they just don't pan out, and so I was really happy that this drug made it to phase 3.
What were some of the characteristics of the drug? What excited you about it? How was it behaving?
We were seeing excellent results. Like patients were um, staying on the treatment without the cancer worsening much longer than we anticipated. Unfortunately, not every patient, but we saw this in often in patients. And overall, it seemed to be well tolerated, especially compared to some other drugs that we had used that attack a similar pathway. Would you like me to tell you a little bit about the drug? So, okay.
Please. Yes.
So Genitolasib, so it is attacking a pathway. So there are very common ways that cancers can grow, progress, and even become resistant to treatments. And many times in estrogen receptor positive breast cancers, we see this pathway activated. And we call it it's a PI3 kinase AKT mTOR pathway. And so we have shortened it to PAM for short. Much easier to say.
Nothing like a good
That's right.
acronym.
We love our acronyms, especially in oncology. So,
Yes.
so the PAM pathway is frequently upregulated. And so what we can see sometimes is if this pathway is overactive in a cancer, even if you're giving an anti-estrogen therapy, the PAM pathway can overcome that treatment. But when we combine it, the estrogen therapy with a inhibitor of the PAM pathway, then we can see much better results. And what we had, what we see frequently is a PI3 kinase mutation, which is one part of that PAM pathway, the P, if you will. And it's very commonly mutated, up to 40% of ER-positive breast cancers. But we've also observed that even patients that don't have one of those mutations seem to benefit. And there's a lot of different ways that the pathway can be upregulated. It could be upregulated through a change in one of the other molecules besides the P. Um, and sometimes you can't even detect like the mutation or why it's upregulated. We can see that we don't see a mutation, but when you give this drug, it seems to work. So there's other ways besides specifically mutating that molecule that can make the pathway run. And so many of the trials for this population have been focused on patients that have a mutation, primarily in the PI3 kinase. But some of the newer drugs also mutate or impact mutations in other areas of the pathway. And so what's interesting about the Victoria 1 study is we decided to evaluate this drug in patients with mutations and patients without mutations.
And let me just stop right there too, because that's, I think, a really good distinction, because I think a lot of times we hear some of these terms like the PIK 3CA, excuse me, and we're like, oh, okay, it's a mutated thing, because we're hearing about the mutation being that, it's something we can target. It has evolved. It's now causing, higher division of cells. The cancer is growing more rapidly. But then it's also important for us to remember that, as humankind, like we have this gene. Right. So and I just bring this back to the BRCA gene, because I think everybody is familiar with that one. And it's like, oh, if you have BRCA, you have a higher risk for breast cancer. And that's not true. Everyone has this gene, right? And so just kind of letting the population know, our listeners know, we carry this, but it's that mutation piece that you're talking about. And so when you're talking about this wild type versus the mutation, we're really comparing what a normal gene would look like and how it would respond versus one that has already been mutated.
Yes. And in this particular case, so just to make this distinction, when I talk about like the mutation, this is not a mutation you were born with. So some tests will evaluate for a mutation you were born with, such as BRCA, for example. But everyone has a BRCA mutation, as you said, but some people are born with a mutated BRCA. So this is not looking at that. This is looking at specifically a mutation that developed in the cancer. So only the cancer cells have this mutation. And
because cancer is so smart.
I know. I wish it wasn't so smart. And this particular mutation, and what we're looking for specifically is a mutation that overactivates this PIK3CA. Some mutations for cancer will deactivate something. So sometimes there are mutations or there are genes that help protect the cell from mutations and genetic mistakes. And losing that gene in the cancer can be bad. But in this case, it is making the gene work better, not deactivating the gene.
Thanks for that distinction. Very important. All right. So now you have these two arms of the trial. Those that we're referring to as the wild type and those with the mutation that has happened not from birth, but from because the cancer is being smart. And now you have this molecule that you're so excited about. Then what?
So we called it study 1 and study 2. It's all within the same study, but study 1, which was presented last week at ESMO, is for patients that have the wild type PIK3CA or no mutation in that gene. And the study 2 is for patients that had a mutation in PIK3CA, and we are still waiting for those results. Hopefully, we will have those results coming within the next year. It's always hard to accurately predict. But yes, so this this study is what makes it so interesting is that it's it's in the population that you would think would be maybe less likely to benefit from this drug. And what's unique about this drug compared to some of the other ones is that it inhibits two parts of the pathway. So it inhibits the PIK3CA, which is the P, of course, and it inhibits the mTOR, which is the M. But when you look at some lab studies, so like preclinical, not like in patients, there's suggestion that it actually just shuts down the entire pathway. So because it's inhibiting these two parts, even the A gets downregulated. And the reason why we feel like in theory this may be more effective is sometimes if you are inhibiting just one part of the pathway, then the other parts start changing and compensating for the one that you are inhibiting, again because cancer is so smart. And so this doesn't allow the cancer to reactivate this pathway in a different way because you're just shutting the whole thing down.
Who are the patients then in this arm of the study, in study 1? Are these metastatic patients who are ER positive then, but do not have this mutation?
Yeah, these are patients with metastatic breast cancer that are positive for estrogen receptor, but HER2 negative. So often when I say ER positive breast cancer, that's shorthand for also HER2 negative. And so they wouldn't be getting any of the anti-HER2 drugs. And these patients are patients that had already received um, treatment when they were first diagnosed. So they got what we consider like very excellent treatment with an aromatase inhibitor, which is an anti-estrogen medication pill, and what we call a CDK4/6 inhibitor, which inhibits a different pathway, and that therapy is given as a combination, and it's been very, very successful. The problem is after patients have a cancer that is growing despite being on that for some time, then the subsequent hormone therapies don't seem to work as well as it did the first when you give the first one. And so these are patients who whose cancer has progressed on what is currently considered the very best type of hormone therapy. And these patients, and what we did was we compared the standard of care, which is a different type of hormone therapy called fulvestrant. And we compared that to giving the fulvestrant with the Genitolasib, and then also have another arm where they got the Genitolasib and a CDK4/6 inhibitor. So 2/3 of the patients got the study drug, which is the Genitolasib, and 1/3 got just the fulvestrant.
So then the results of this study, right? So just for my own understanding, we have fulvestrant, also known as Flazeldex, that patients are receiving. And then we have those who are receiving Flazeldex plus the I can't pronounce it, Genitolasib. G. Okay. Yes. Excellent. Okay. And then both of them are doing well on this, or did the one with the molecule show that it was doing better than the standard?
Yes. So, yeah. So, moving to the results. So, what we saw with the standard of care therapy, again, these are patients that already received a different type of hormone therapy. So their cancers are showing some type, some level of resistance to anti-estrogen therapy. So giving a different anti-estrogen therapy, the fulvestrant, um, the what we call the progression-free survival, or how long the patient was on the treatment before the cancer started to grow, was only 2 months. And so what this demonstrates is that that standard just isn't a very good standard. If you look at some of the scientific curves, you can see that um, like about half of the patients, the first time they checked a new scan, their cancer had already grown with the fulvestrant. So we really need something better. Like that is clear. Other studies have shown this, but what we know is that this standard medication fulvestrant is just not cutting it. And so we had two arms and that compared to that. So we kind of call it a doublet and a triplet. And so when we first studied the drug, in that phase 1, we used the triplet. And so we gave the fulvestrant with the CDK inhibitor called palbociclib or Ibrance. And that is kind of giving it a CDK inhibitor again, because all these patients had already received it with the first treatment. And the Genitolasib, so the triplet. And the other one was to give just the Genitolasib with the fulvestrant without the CDK inhibitor, because the question is appropriate. Do you need 3 drugs, or can you just get, especially when you already kind of got a similar drug before, or can you just give 2 drugs? Because it's important to give the very best therapy, but we also don't want to give too much. So we want the Goldilocks, right? We want not too little, not too much. So we were testing that. And what we found was both of the arms with the Genitolasib were significantly better than the fulvestrant by itself. So the triplet performed the very best, but the doublet was also very good. So they were a lot better. So the fulvestrant by itself, again, it was just 2 months. So the average progression-free survival was 2 months when you got the fulvestrant by itself. And if you got the triplet therapy, on average, the progression-free survival was 9.3 months. And so much, much higher, much longer. And, that's the average. Actually, some patients are still taking the drug. The doublet therapy, so just the 2 drugs without that CDK inhibitor, had a progression-free survival of 7.4 months. So again, a lot better than the fulvestrant by itself. A little bit shorter than the one with the palbociclib, but also very good.
Yes. And I don't know if you have the stats right in front of you or know this offhand, but then what is the progression-free survival typically for fulvestrant plus Ibrance?
We don't have good data on that.
So there's a chance then that this new molecule that we're calling G could replace that.
Yes, yes. So we have so there was a phase 3 study with fulvestrant plus abemaciclib, which is a different CDK inhibitor, and that improved the progression-free survival also, the the populations were a little bit different. Even if the eligibility criteria are similar, sometimes the patients that actually get enrolled on the trial, their cancers can be a little bit different. But we saw that the absolute difference when you added the abemaciclib to the fulvestrant was about 1 to 2 months difference. So the difference between these patients on this trial was much more than what we saw with the abemaciclib, but it's really not fair to directly compare these because the populations aren't exactly the same.
I have a burning question. So if you start these trials, I'm assuming here, maybe you're starting these trials around the same time. Why would data be ready for one arm and we have to wait a year for the other arm data to come?
Um, the reason is because the PIK3CA mutant population enrolled slower. So that's just why. We actually are just wrapping up enrollment for that arm. And there could be various reasons for that. So about 40% of all comers, all of ER positive breast cancer are going to have a mutation and 60% aren't. So there's just a larger population to begin with. And so that arm enrolled faster. And so we had the results, and so we released them. Hopefully we'll have the results for the mutant population soon.
Okay, no, as we're learning about clinical trials, how these things evolve. I always compare our podcast, Breast Cancer Conversations, where we talk about all things breast cancer, does really well. We get a ton of downloads, a lot of listeners. And I always say, for not being a true crime drama, I'm really impressed with our listenership. But then hearing this story, I'm like, okay, what comes next? What results are we going to find? And, drum roll, please. Why don't we have everything all at once, right? And so I appreciate that insight. And so, as you were mentioning, so you had the results, you wanted to release them. Do you think that's going to now change practice when people return from ESMO, they're back in the clinic, they have this new data? How do you think that's going to translate in the real world clinical setting today?
I hope it is going to change practice. It's not going to happen today, unfortunately, because nothing moves as fast as we want. So, first of all, this was presented in abstract form. So, the publication is not out yet. So, it's very important to publish the results because when it's in a journal, it is reviewed by your peers, by other scientists to make sure that it was run correctly. They give there's much more detail that can be included in the manuscript than the short time you have to present the results at a meeting. And so that manuscript has been submitted for publication. We are waiting for the review. So having that manuscript out is very important. And then also, we have to get approval of the drug by the FDA. So
Got it. Okay. So a lot more steps to happen.
some drugs now are already FDA approved for other reasons. And so a clinical trial may show great results in a different population, maybe even a different type of cancer. And then you can get access to that drug much faster. But because this is a brand spanking new drug that's not been FDA approved, then we have to submit it to the FDA, which we are planning on doing. And then the FDA has to do their review, and then everyone is just anxiously waiting for the approval and how they will approve it. So sometimes the FDA will look at all the data and say, well, you wanted to approve it for these patients, but we think only these patients should be approved for. So I'm hoping within the next year it's going to be available. I hope it's shorter than that. I really do in my heart feel that based on the data, it is going to be approved. But I know, you can never make predictions when it comes to the FDA. So unfortunately, we can't use the drug right now. Patients that are on the trial can continue to get the drug. And we are starting to enroll a new trial with this exact drug for patients that are getting their very first hormone therapy for metastatic disease.
Oh, wow. Oh, that's great. Excellent. And how is the drug administered?
So it's IV, like elephant in the room. I will acknowledge this has been a point of contention. So it's not a pill. So it's IV. So it's given for 3 weeks in a row, once a week for 3 weeks, and then a week off. So on a 4-week cycle. Now, fulvestrant also isn't a pill. So that's the hormone therapy drug. So fulvestrant is a shot that you have to give every 4 weeks. So no matter what, when you're doing something with fulvestrant, it's not going to be an all oral regimen. What I can say is, so a lot of people have asked, like, do you think patients are really going to want to do this because they have to come in frequently for IVs? And what I say is, well, I mean, we have to see. So honestly, there might be some patients who just say, no, I do not want to come in for an IV that often. And that's why it's so great to have options. But I think what I have observed is one is if it's the very best treatment, then it doesn't matter how it's administered. You're going to want the very best treatment, even if it means getting an IV. You can in reality, we have patients on IV treatments all the time, and we're flexible. In the real world, where like I have to go to a wedding this week, or I plan this trip, and the oncologist says, "Great, you should do that, and we'll just pick up when you come back." So there's that. There's also practical issues. Like sometimes, like pills are harder to get approved by insurance, or there's a higher copay. So just the way the billing occurs in the United States, that's a whole different podcast.
Oh, yes, yes.
But sometimes like it might actually be less expensive to do an IV drug for the patient than to pay a copay for a pill. So there's that issue. And then I think what may also be possibly the most important thing is that side effects. So we are seeing less side effects with this drug than in what we have observed in other studies that inhibit this pathway. And so I think if you present all the information to a patient, if they have good tolerability of the drug and it's working well, then doing it IV is a good compromise to achieve that. So I really think it's not going to be a barrier, but I will acknowledge that there is some hassle with the IV treatment.
In full transparency, also, are you able to talk about some of those side effects that people are reporting?
Yes, absolutely. So I will start off by saying that this is not the easiest pathway to inhibit. So as you mentioned before, we have this gene. We have the gene for a reason. And so it does important things. And so when we start inhibiting things that are in our body for a reason, then we have side effects, just like estrogen, right? So just doing an anti-estrogen, there are things like hot flashes and other side effects, which you unfortunately are probably aware of.
Yes, way too familiar. Yes.
And so this pathway is important, and one of the things that it regulates is insulin and glucose control. And so one thing that has been observed with a lot of the especially PI3 kinase inhibitors that are in pill form is elevated glucose levels, even in patients that don't have diabetes. So like when patients start some of the inhibitors of this pathway, we have to like give them a glucometer and tell them, I know you've never had problems with your blood sugar, but you need to start checking your blood sugar and let us know if it gets elevated. And then sometimes we have to start medications for that. But we see that. So we did observe that in this trial. But it was far, far, far less than what was observed with the pills that are approved. So that's like one nice thing. The other things that we are seeing that have been seen with other PI3 kinase inhibitors is mouth sores. And that is, we have some tricks for that now. So we learned that if you do a mouthwash, we can prescribe a mouthwash that can help prevent the mouth sores from ever occurring. And then we have other, things to like numb mouth sores, et cetera, if that occurs. But we do find that if you stick with it, the mouth sores tend to just kind of slowly go away. The longer you're on the drug, the body kind of adapts to it. And then some people get a rash also, less frequent than the mouth sores. But what we have recommended, as well as with other inhibitors, is like if you take an antihistamine, then that can help prevent it. And again, the rash like goes away. Like I had a patient on this study who had both mouth sores and a rash, and after about like by the end of the second cycle, like those like just were gone. So so the one good thing is that it's not like a side effect that will hopefully be there the entire time, but it's possible that we might have to get you over a hump while you're on this to deal with some of those side effects.
Yeah. I appreciate you sharing that because I think even just knowing what to expect, and there's all of us I know listening to you, it's like, oh my God, I'm that patient that's going to get absolutely everything, or I'm that patient and you're telling me all these things and I can tolerate it very well. So, it's just kind of knowing the information and knowing how to get ahead of it.
Absolutely.
And so you were mentioning also that you're recruiting or going to be recruiting soon for this new study.
Yes, it's actually open, just recently activated. We have it at our site. I don't know how many sites in the U.S. are open yet. It always as a new study comes on, it trickles in. So it's a little bit. So we're giving the treatment, the triplet therapy. And we're going to get we're going to also investigate giving it with a different CDK inhibitor, so called ribociclib. So the patients will be able to take either palbociclib or ribociclib with the fulvestrant and the genitolasib. It's for patients who have never received any treatment for their recurrent breast cancer. But it's for patients at higher risk, or maybe more aggressive cancers. So patients whose cancer metastasized while they were still taking their adjuvant hormone therapy or stopped it within a year. And the reason why we chose this more aggressive population is because that first line therapy is just so good for many, many patients. And we don't want to give everyone 3 drugs, especially one that has more side effects, if really not everyone needs it. And so the vast majority of patients probably can do the regular just 2 drug regimen at first. And if and when the cancer grows, then consider this drug. But we found that there is a population of patients whose cancers seem to be more resistant to hormone therapy that don't do as well on that first treatment as patients that do not have signs of that endocrine resistance. And so we want to do better for those patients. And so this trial is specifically for that population. It's a little bit of a more restricted population, but I think it will be a great option for patients that are in that situation. I hope it will be a great option.
And how do people find it? So you're saying right now it's at MD Anderson. Is it a derivative of like Victoria-3 or something? Or what's the name of it?
You've done this before, Victoria 2.
Oh, 2. Okay. Excellent. Excellent. Because I know our listeners too, we have a very active community, and I'm so grateful because, we're providing education to people, hopefully in understandable layman terms, in plain English. And, I always say whether they attend one of our support groups or listen to a podcast, like they'll go up to their oncologist and ask like, hey, I heard this, like, how can we get more information? Am I eligible? Tell me all of the information. So I love just being able to bring this information to the community.
Yes. And I will say, if I'm sure many of your listeners are familiar with clinicaltrials.gov. So if you you can search for Victoria, and it's spelled VIK. It's because of it's similar to PIK3CA, which is the reason.
Yes. I love that.
And
A play on words. Why not?
I know. And or you could just put in the drug name, Genitolasib. But if you can search for it like that, and then on clinicaltrials.gov, it will give you a list of the sites that are open so far. So you can even look to see, is there a center close to where I live that has this trial. So that's a good way to look at this, because I know not everyone lives in Texas. So,
well, Dr. Layman, this has been a fascinating conversation. I actually look forward to inviting you back when we get the results within the year for the other arm that we were talking about earlier. So, coming soon. But is there anything else that we haven't discussed that you would like to share?
I guess, the key here is that we will see if and when this new treatment gets FDA approved. In the meantime, if patients have a PIK3CA mutation, there are other options to target this.
Fantastic. Well, thank you for taking the time to speak with us and our community and sharing a deep dive in the Victoria 1 study and what's to come.
Thank you so much for inviting me. This has been really fun.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400+ programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.